Chapter 18 discusses disorders of thought, emotion, and memory. So we're going to start with talking a little bit about some incidence and prevalence numbers of different mental health disorders. Mental illness is quite common among Americans. 1 in 5 people will experience the consequences of a psychiatric disorder within any given year. 1 in 25 live with serious mental health illnesses like schizophrenia, bipolar disorder, or major depression. 50% of all chronic mental illness begin before the ages of 14. So this is something that is prevalent not just in young and middle adulthood and later, but that we see pretty prevalently in adolescence. And 30% of people with a physical disorder also have a coexisting psychiatric disorder. And I think that that's really important to understand because for a lot of students, you may be thinking, you're going to work in maybe an acute care setting. Your intention is not to necessarily work in psychiatric settings, but know that 30% of the patients you care for in an acute care setting for some physical issue will also have a coexisting psychiatric disorder as well. So this is not a area that you can necessarily avoid. You will care for patients who have many of these diagnoses. There are multiple causes of psychiatric disorder, as with most kind of complex neurologically based things. It's probably a combination of some genetic predispositions combined with a multitude of environmental factors that lead to these different disorders. And probably for each disorder, what those triggers and genetics look like underneath are probably vastly different. So we have a long way to go in our full understanding of these causes. But we do know that there are some biological things, again, things like genetics. There are also certain brain defects involved. Toxins can play a role as well as changes that occur during fetal development. There are psychological triggers like stress, early loss of a parent, or early neglect. And there are a lot of environmental issues as well, things like dysfunctional family dynamics, different cultural expectations, and substance use. And this, again, is just kind of a short description of different things. Probably many, many more could be listed here. I wanted to mention something called the stress diathesis theory because this is sort of a leading theory right now in the field of mental illness. It combines genetics, the diathesis, and the environment, which is the stress, and looks at the fact that they both kind of contribute again to the development of psychiatric disorders. And it also considers the influences of things like early trauma and what we call adverse childhood experiences, or ACEs, on mental and physical health. So ACEs, or adverse childhood experiences, are things like maternal neglect, physical and sexual abuse. There are many websites that deal with the discussions around ACEs. If this is something that interests you, you will get more information about ACEs, and you'll talk about this at several different points throughout the curriculum here at MSOE. So this is a bit of an introduction to it. But essentially, there are different questionnaires that gauge someone's essentially number of ACEs that they encountered as children. And the higher that number, the more susceptible or prone we would consider that person to be as far as developing like mental illness or issues kind of later in life. And not just mental health problems, but also chronic health issues. It's not, it's both mental and physical disease that these things can predispose a person to. And the theory is that this kind of prolonged activation of the stress response that occurs when children are exposed to these adverse experiences leads to these kind of profound long-term physical changes. Early adversity seems to alter the DNA in the brain through a process called methylation. So this isn't just about, stress and trauma, like leaving behind, psychological scars that someone has to work through. there's evidence that it literally changes brain DNA because of these stressors. And so, it's deeper than just the stress itself. And then genetic vulnerability and environmental influences then play these significant roles in the development of mental illness. Um, so other things, some people are, experience things like early childhood trauma and don't seem to develop, really as much problems later on, and others, do, even if those numbers are the same, right? Like even if their exposure is the same, there's always differences in how people express those things later. And so that's where this whole notion of the genetic vulnerability of an individual and other environmental influences also kind of play a role in how deeply these ACEs will impact somebody. So some of those things might be their age at the time of these childhood experiences. It might be the developmental stage that they were in. Some developmental stages might be more critical than others as far as their impact of ACEs on that individual. Um, the support system seems to really make a difference as well. If someone is experiencing childhood trauma or adverse childhood experiences, but they also have a built-in support system that seems to be able to kind of ease or ameliorate some of that impact of those traumas. So outside support is really critical. Other things like cognitive deficits, cognitive deficits would probably make someone more vulnerable to these changes. Other things like pre-existing neurophysiology and the nature of the trauma also impact here. So while ACEs questionnaires try to kind of boil this down to a couple numbers, right? It's really kind of an oversimplification. And essentially, at the end of the day, what we're thinking is happening here is all of these changes and all of this kind of excess stress response early on prevents the brain kind of maybe throughout life from being able to like appropriately regulate its overall response to stress. And then that shows up as different mental illnesses throughout the lifespan. Another important concept in how the brain functions is information processing. So the areas that help us to process information are distributed kind of throughout the brain. Um, Neuroplasticity is a common term we use in neurological discussions as well, and that refers to the capacity of the nervous system to change its structure and function in response to biological, psychological, and environmental events. And so that neuroplasticity, again, is its ability to change, to kind of make new connections, to get rid of old connections that are no longer serving us, and all of this in response to kind of what's going on around us. But when the integration of all this information processing, as well as the impacts of neuroplasticity, become dysregulated, that's when psychopathologies can result. And so for people with trauma, for people with brain injuries, or people with degenerative changes to the brain, that can impact our ability to process information appropriately, and it can also impair things like our cognitive functioning. So we've talked a little bit about neurochemicals already in the context of discussing different disorders of movement. And so I'm going to kind of go back over them again because some of these are going to be ones we've already talked about, but they don't just impact our ability to move. They're also implicated in different mental illness and psychiatric disorders as well. So we've already talked about acetylcholine and its impact on movement, but acetylcholine is also important to things like learning and memory, and imbalances in acetylcholine are linked to things like neurocognitive disorders. So things like Alzheimer's disease is linked to an imbalance in acetylcholine. Dopamine, which we've already talked about as far as movement, is also a neurochemical involved in the diseases of schizophrenia, in different mood disorders, and in different anxiety disorders. And it's usually like with schizophrenia, for instance, it's a preponderance or too much dopamine. So some of the medications we use end up blocking dopamine. Norepinephrine and epinephrine are implicated in mental health disorders like schizophrenia, mood disorders, and anxiety, just like dopamine, as is serotonin. Same things, mood disorders, anxiety disorders, and schizophrenia. as well as GABA. That's our inhibitory neurotransmitter involved in schizophrenia, mood disorders, and anxiety disorders. So um, I think, this also speaks to, again, kind of the complexity of a lot of these mental health disorders in that most of them, um, have multiple neurochemicals that are involved. So I also want to give you some definitions of the different types of memory because when we get into the neurocognitive issues, this will become important to understand. But one type of memory is our immediate memory. And this is memory that we imprint for maybe seconds to minutes. And this really impacts just our overall ability to pay attention. If you have someone who can't recall things that they were told, moments ago, they're not going to also be able to attend to anything, right? Like your attention to things is really predicated or is really hanging on your ability to like kind of understand and process and remember what you're hearing, right? Otherwise, what you're hearing sentence to sentence isn't going to make much sense and you will lose attention. And so, as someone has neurocognitive decline, as that immediate memory starts to become eroded, it becomes very difficult for them to attend to things around them. Recent memory is, and sometimes we call this short-term memory, is the memory that we imprint for minutes to days. And sometimes those things are things we'll forget, and sometimes they're things that get further imprinted into what we call remote memory or long-term memory. And that's memory that can last years. It can last, an entire lifetime. And this type of memory requires us to make actual structural changes to synapses within the brain that again imprint those memories into our system. So a little bit more about learning and memory or our thoughts. The brain really integrates that whole process of learning, memory, and emotions. And people with psychiatric disorders or with brain injuries often have trouble in those proposed pathways for things like learning and memory. And these difficulties influence behavior and can result in significant problems for people in things like their daily living and functioning and relationships and work. And so when we talk about many of these disorders that we're going to talk about in this presentation, many of them, sometimes the criteria for deciding whether or not someone meets like the classification of a disorder is that it's starting to impact like their ability to work or to live or to function in society or to interact with family and friends because the severity of those disorders often will impact their ability to do those things. So the origin of the manifestations of mental illness. So we assume that this is some kind of alteration in brain neuron functioning. And it may involve things like destruction of certain areas of neurons, or it might be different alterations in how neurons are connected among the different regions within the brain. So we're going to start by talking about the disorder of schizophrenia. So schizophrenia is a chronic mental illness that is quite debilitating for patients. It's what we term a psychotic disorder, and it involves the disconnection between someone's thoughts and their language. It affects things like thinking, feeling, perceiving, behavior, and how people really experience the environment. It seems people with schizophrenia really struggle to filter out a lot of the stimuli that are coming in from the environment. And, in our day-to-day lives, we end up doing that a lot, just filtering out kind of a lot of things around us that don't really matter so we can focus on what does. And so imagine being someone with schizophrenia who just can't really filter those things out. So schizophrenia affects people's thoughts, their feelings, their perceptions, their behavior, again, because they can't filter out a lot of these stimuli, and so they're having to kind of attend to and deal with much more than most people would. The typical onset of schizophrenia is between the ages of 17 and 25 years old. And usually when we see onset at these ages, onset at this time usually affects more men than women. Women tend to, if they um, do get a diagnosis of schizophrenia, tend to do that maybe later in life because by the time people are about the ages of 50 to 60, there seems to be an equal amount of men and women who are affected by schizophrenia. There's also a genetic link with schizophrenia. First-degree relatives of a person with schizophrenia have a tenfold greater prevalence of the illness. So some sort of genetic susceptibility at play here. So to diagnose someone with schizophrenia, and this is pretty common in the field of psychiatric diagnostics, we use something called the DSM-5. It's a diagnostic and statistical manual, I think is what it's called, of psychiatric disorders. But they come out with these new versions periodically with all the mental health disorders that are in it, and it has listing of different criteria that must be present in someone to diagnose these disorders. Because as you can imagine, there's really no like definitive, there's no blood test here, right? There's no, we can't do a scan of someone's head and tell you definitively what's going on. So the diagnosis of the majority of these mental health issues is truly just by symptoms. And so the DSM-5 gives us lists of symptoms that need to be present, and then usually how many of them would be required for diagnoses, as well as how long someone needs to be experiencing them and how like prevalent they are, like how often they're experiencing them. So again, these are really common things you'll see in the diagnostics of psychiatric illness, just again, because there's not really a definitive way, it's all by symptoms. So having said that, so with diagnosis of schizophrenia, they need 2 or more of the following symptoms to be present for a significant portion of 1 month. So we would talk to a person about what was going on over the last month, and if 2 or more of these things were happening like a lot or most of the time, they may meet the criteria for a diagnosis of schizophrenia. So it's things like experiencing delusions or hallucinations. It is the appearance of things like disorganized speech, disorganized or catatonic behavior, or what we call negative symptoms. And I'm going to go over what those all are momentarily. So again, 1 or more areas of functioning must be significantly impaired, and continuous signs of the disturbance must persist for at least 6 months. So not only do they need to have these symptoms, but it also needs to be affecting their ability to function, as we talked about before, whether it's work, relationships, whatever it might be, and that needs to be present for 6 months for a definitive diagnosis. So we'll talk a little bit more about those kind of manifestations or what we see in schizophrenia. And so when we talk about schizophrenia symptoms, we talk about one group of symptoms that we call positive symptoms and one group of symptoms that we call negative symptoms. And so positive symptoms, the definition of this are like heightened or excessive behaviors, and negative symptoms are the absence of typical features. One thing also to understand with schizophrenia treatment, when people are experiencing negative symptoms, they're much more difficult to treat. Okay. All right, so these are positive symptoms. And again, these will be things that are like heightened or excessive behaviors. So what that really means is these are things that like people normally do, but for somebody with schizophrenia, they're like, yeah, just bigger or more confused or more common or like, I don't know, just stranger in a sense, right? So things like incomprehensible speech. So, everybody has speech, everybody communicates, right? Essentially. But in someone with schizophrenia, that speech becomes incomprehensible or not understood. And so it's a normal behavior, but it's changed, right? Delusions are positive symptoms. These are false ideas. These are ideas people get in their heads that they convince themselves that are true. And then there are hallucinations, and these are different than delusions because they're not just ideas. There's some sort of sensory issue that someone's having that they really think is happening. So like a hallucination is like seeing something that's not there. And for the majority of people with schizophrenia, it's hearing things that aren't there. These auditory hallucinations, things like hearing voices, are really the most common type of hallucination that we see. There's also catatonic behavior, where someone is just kind of like sitting there, they're not able to communicate, you're not able to communicate with them, no emotion, no movement, that kind of thing. There's also enhancement or a blunting of the senses in general. You can see either. enhanced sense of smell or taste, whatever it might be, or it might be completely blunted. And then the final positive symptom is what we call sensory overload, again, because they can't really screen out any of these external sensory stimuli. So they get what we call sensory overload. Just a couple terms as well. Sometimes with the notion of incomprehensible speech, sometimes these people with schizophrenia engage in the creation of neologisms. Those are the use of like invented words. Sometimes it looks like what we call derailment, where they're making like really loose associations between things that aren't necessarily associated. Sometimes the speech is tangentiality, and that's where they like can't stick to the original point, right? Like you're talking about something, there's a specific topic, but they're just kind of like all over the place with different tangents. They can't stay on track. There's also incoherence, where they're just kind of losing any logical connection of what they're saying. And then one of my favorites, which is something called word salad, where they're just using a lot of like groups of just totally disconnected words, just throwing words at something that don't make any sense together. Um, yeah, and delusions again are things like false ideas. And the thing that makes delusions different, like people get ideas in their head, right, that aren't correct. But with someone who's experiencing delusions, no matter what you do to try to correct the delusion, there's no way you can, right? Like that's just going to be a thing that they think. They range anywhere from believing like people are watching them, that's called ideas of reference, to believing they are being punished or manipulated by other people, that's delusions of paranoia. Some folks also have like delusions of being a historical figure. Those are common and they're called grandiose delusions. And sometimes the delusions include a belief that the affected person can control others with his or her like thoughts. So just a little bit more information about a couple of those kind of positive symptoms and sort of the variation in what you might see. And then here are negative symptoms, remembering that they are far more difficult to treat than the positive symptoms. And so the first one there is absence of normal social and interpersonal behavior. So they just lack any ability to engage normally in social interactions. Alogia is the tendency to speak very little, so they don't speak much at all. Avolition is a lack of motivation for any sort of goal-oriented activity. Apathy is a lack of interest or concern. Affective flattening is the lack of any sort of emotional expression. Inappropriate affect is when someone's affect does not match the situation. Anhedonia is the inability to experience pleasure in normally pleasurable events. And then sometimes people have, I guess, an overall like blunted response to pain stimuli as well. And those are the negative symptoms of schizophrenia. So the neurophysiology of these symptoms is really largely unclear. Potentially, what we're thinking is it could be this overall dysregulation of dopamine and serotonin pathways. We do use medications that would attempt to regulate those neurotransmitters with some success in these disorders. There also may be a deficit in GABA associated with some of the impaired cognition that we see. And when we look at brain imaging on people with schizophrenia, we do see multiple areas of abnormalities on brain imaging. So these include things like the excessive loss of cortical gray matter, abnormal cortical thinning. We see a reduction in the number of synaptic structures on neurons. We see reduced dendritic spine density, especially in the pyramidal neurons and like the prefrontal cortex. We see an arrested migration of hippocampal neurons. We see enlargement of the lateral and third ventricles. So those are the spaces inside the brain that hold things like cerebrospinal fluid. Those get larger, which would indicate that there'd be less brain mass. And then we see a reduction in things like frontal lobe and temporal lobe. We see a reduction in the amygdala and diminished neuronal content in the thalamus. The amygdala is responsible, I think, for like kind of a lot of like our like things like aggression and some of the regulation of like our hormones, or not our hormones, excuse me, our emotions and that kind of thing. So it sometimes, logically makes sense that there might be amygdala impairment. Things like the frontal lobe, which largely like is, higher level functioning of thinking and seat of like things like personality, also kind of makes sense with some of the things that we see. So then we'll move on to some of the depressive disorders. And there are a lot of different types of depressive disorders. There are 8 different types of depressive disorders that are included in the latest version of the DSM. I think it's DSM-5. I have several of them listed here. Things like major depressive disorder, persistent depressive disorder. We also include things like premenstrual dysphoric disorder. There's something called disruptive mood dysregulation disorder. There's also depressive disorder that can be due to other medical conditions or the use of substances. And then bipolar disorder is also included here. Other things that I would mention are things like seasonal affective disorder, psychotic depression, prenatal depression, and postpartum depression are also some different types or situational things that people might experience. So we're going to just talk though about major depressive disorder. So this is a very common mental health illness. 6.7% of adults and 12.8% of adolescents will experience MDD. And typically the age of onset where we would see this was around someone's mid 30s, but now we're seeing an overall increase of incidence much earlier. So it's like kind of trending more towards between the ages of 18 to 25 on average, because we're starting to see much earlier ages of onset for MDD. Depression is also pretty common in older adults, and it often appears kind of along with things like confusion. And so, we sometimes undertreat depression in older adults because we think, it's maybe confusion, it's delirium, it's dementia. And so one of the things we do kind of a lot, especially in the field of geriatric psychiatry, is really trying to piece out which one of those disorders it really is so that we can properly treat what's going on with that older person. One of the hallmarks of depression, though, is this overall loss of interest and engagement in pleasurable activities. So things that gave someone pleasure or they were interested in before now become something they don't want to engage in at all, or they get, no satisfaction from. Other clinical manifestations that can become common are things like suicidal ideation, a lack of appetite, or for some, excessive appetite. Other things we see are poor concentration, difficulty in decision making, low energy, and feelings of worthlessness. You may also see some physical symptoms like decreased motor skills. It often leads to things like disordered sleep. For some, it's a preponderance to insomnia, and for some people, it's too much sleep, like they just want to sleep all the time. So the sleep we see might be, different based on the person. And then we also see an increased incidence of things like substance abuse and substance use disorders in patients with MDD. So to diagnose depression, the criteria here for diagnosis include presence of symptoms that we just kind of mentioned most of the day, nearly every day for a minimum of 2 weeks. And then those symptoms also need to interfere with activities such as work or functioning. And when we say functioning, it's like, day-to-day activities, ability to interact with friends and family. Those are the kind of things that we mean by functioning. There are many biological theories that have been identified to kind of explain why people develop depressive disorders. Again, not something that we fully understand, but some of the theories include like maybe inflammation of the hypothalamic pituitary axis that causes kind of an overall hyperactivity. Other things like low levels of neurotrophic growth factors have also been associated, and sometimes low vitamin D levels have been associated. Again, these are just kind of theoretical. And another thing that we commonly associate here are different neurotransmitter dysfunctions, especially the neurotransmitters of serotonin and epinephrine. And the majority of our medications that we use for depression aim to increase the overall levels of serotonin in the brain. So in the treatment of depression, antidepressants are very common. Again, they most of them act to increase the activity of norepinephrine as well as serotonin. So the most common drug here is SSRIs. I'm sure you'll discuss those in pharmacology, but those are selective serotonin reuptake inhibitors. So essentially what they do is they increase the amount of time that serotonin can act at the synapses in the brain to kind of increase its overall activity. Another treatment that is sometimes used, but is generally reserved only for people with really severe depression that has been sort of intractable or hasn't been able to be helped by all of our other treatments, may undergo something called electroconvulsive therapy, where we apply a high voltage of electricity directly to the brain. Patients are usually sedated and under significant amount of safety features, but this can be very helpful for people with severe depression. It's usually helpful for kind of just a short period of time, and usually doesn't, for most people, I don't think really reverses depression, but it usually gives them some respite, but often has to be kind of repeated. We're sometimes successful with using light therapy, especially for patients maybe with um, seasonal depression. Um, but the best type of treatment that we've found is really this combination therapy of medication, so things like SSRIs, also combined with different interpersonal therapies. There's also cognitive behavioral therapy that's very helpful, and something called problem-solving therapy. But I think, again, the bottom line here is that therapy combined with medications is really the best way to generally treat depression. So we're going to move on to different types of anxiety disorders. There are a lot of different anxiety disorders. So things like panic disorders fall into here. Panic disorders are like this intense fear of something happening. Usually what someone is afraid of is not something that's necessarily rational or real. And for people with panic disorders, that fear is also accompanied by physical and behavioral symptoms. So they get, intense, like maybe elevations in their respiratory rate and heart rate, their blood pressures go up, they feel short of breath, they get chest tightness, they get chest pain, and almost, for many of them, they think they're having a heart attack. So the physical symptoms are very real and very overwhelming. But the underlying thing that they're worried about is usually nothing that would be, rise to the level of the fear that's generated during a panic disorder. It's very real for them, but obviously occurring in a kind of disordered way. There's also generalized anxiety disorder, and this is characterized by chronic and excessive worry and anxiety that interferes with daily activities and relationships for the majority of days for at least 6 months. And so again, this chronic excessive worry makes it difficult for people to interact socially, interact with their families, go on with their day-to-day lives, interactions, run errands, right? Whatever the things they need to do. It's difficult for them to work because they've constantly got this worry and anxiety that's preventing them from being able to do what they need to do. So that would happen again on the majority of days. So it's not just every once in a while, it's like 6 months of this being persistently occurring. Obsessive compulsive disorders are also a type of anxiety disorders, and this is this overall need to repeat these often distressful but uncontrollable thoughts, which are obsessions, and then to engage in compulsions or behaviors, just again repeatedly without being able to stop, to be able to kind of like using it almost as a way to sort of decrease anxiety. And there's also things like social anxiety disorder. This is actually a type of phobia where someone has just, again, an outsized fear of social interaction. The major mediators of all of our anxiety disorders appear to be the neurotransmitters of GABA, norepinephrine, and serotonin, as well as dopamine. We think it's probably an underactivation of the serotonergic system and an overactivation of the adrenergic system. So overactivation of things like of norepinephrine, those things that kind of like amp people up, and an underactivation of things like GABA and serotonin, which tend to like kind of calm people down or reduce anxiety levels. And so when those two systems get out of balance and we're acting more toward that adrenergic side, then we start to develop the signs and symptoms of anxiety. Okay. And so a lot of the time, the way that we treat anxiety disorders are with medications that kind of blunt that adrenergic system or enhance the action of things like GABA. So we use things like benzodiazepines, because they are inhibitory in nature to kind of counteract that imbalance. Okay. So again, the neurophysiology is really this underactivation of the serotonergic system or the GABA system. Those kind of systems that sort of like chill us out, like quiet things down. And then we have an overactivation of the adrenergic system. Other things that we often see in the brains of people experiencing different anxiety disorders, they often have hyperactive amygdalas. They also have hyperactive limbic and cortical prefrontal cortex, especially in panic disorders. So, a lot of these areas of the brain responsible for things like fight or flight or processing of emotions or executive functioning and thinking are like hyperactive in patients with anxiety disorders. The best way it seems to treat anxiety disorders is to use things like cognitive behavioral therapy. So, cognitive behavioral therapy is essentially like the bottom line of it is having patients um, kind of rewire the way they think about certain situations. So a lot of the time with, as we mentioned, with anxiety disorders, people are really afraid or worried about things that don't necessarily require that level of worry. And so cognitive behavioral therapy attempts to kind of reshape the way that people consider those situations so they can start to see them as kind of less of a threat. And some of that involves exposing people to certain worrying situations and letting them kind of work their way through it to see, okay, this is something that I'm capable of managing. That's really the root of cognitive behavioral therapy. Very helpful type of therapy for anxiety disorders, for it helps with depression. Probably one of our most commonly studied and commonly used mental health therapeutics out there. Often too, anxiety disorders can be helped with things like SSRIs to increase that serotonergic pathway, and also benzodiazepines to kind of blunt the adrenergic overactivity. And we're going to move on to a discussion of dementia. So, definition of dementia, it is impairment of short and long-term memory, and it's also associated with things like the loss of abstract thinking, overall impaired judgment, and the loss of other higher cortical functions, and sometimes also involving things like changes to personality. There are many different things that can cause dementia. It can be caused by any disorder that permanently damages large association areas that serve memory and learning. So remember when we talked about information processing, we mentioned that there are many areas throughout the brain involved in information processing that help us to store memories and to learn. And so anything that would damage any of those interconnected pathways can lead to things like dementia. So there are a lot of different types of dementia. We're going to talk about Alzheimer's dementia, but there's also vascular dementia. This usually happens in patients who have different types of vascular disease. So usually cerebrovascular disease. So the arteries supplying the brain to the heart are damaged. And so these patients are probably ending up having multiple small like brain infarcts repeatedly over an extended period of time. And as the number of kind of like small infarcts or small areas of damage to the brain starts to increase, then that starts to like interfere with more and more of those information processing centers, right? It interferes with like the different connections between them. It interferes with some of those centers themselves. And over time, that starts to show up as dementia. There's also frontotemporal dementia. There's Creutzfeldt-Jakob disease, and that's one of the prion diseases. Not super common, but that's a way that people can get dementia. There's also something called Wernicke-Korsakoff syndrome, and this is a type of dementia people get who have chronically abused alcohol. And then there's Huntington's disease. I think we're going to talk about Huntington's disease um, at some point, maybe in our next lecture, but that is another um, brain disease that can cause dementia. But we're going to focus on Alzheimer's because it is our most prevalent cause of dementia. So it's 60 to 80% of all cases of neurocognitive disorders are caused by Alzheimer's. Um, this is 5.2 million people in the United States. The incidence of Alzheimer's increases with age, and the number of people affected by Alzheimer's is rising relatively rapidly, primarily because people are just overall living longer. So the longer you live, the higher risk you have. So the clinical manifestations of Alzheimer's, we talked in 2015 about things like the mini mental status exam. That's one of the assessment tools that we can use to assess neurocognitive disorders. And so if you think about or remember back to some of the tests that you did in that exam, whether it was asking people to like follow simple commands or to remember words, to do like simple mathematical concepts, those are the kind of things that we start to see decline in patients with neurocognitive disorders. The course of these diseases is usually kind of insidious, so it kind of comes on slowly and they slowly decline. That's what we mean by insidious. And it's progressive, meaning that people just kind of progressively get worse over time. These disorders don't, improve. They only just kind of gradually get worse. The typical survival time for someone diagnosed with Alzheimer's is about 8 to 10 years. They lose their short-term memory. They often develop difficulties with language, and changes to their behavior are very common. Those are kind of the three big buckets of changes that we see with people with neurocognitive disorders. And the changes occur in stages with varying manifestations. Now let's look at some of the stages of Alzheimer's dementia. Stage 1 is really what we consider no overall impairment. These people are able to still kind of function normally, but they may be starting to notice some just general forgetfulness. Stage 2 is still a very mild form of AD, but people may be noticing like some occasional short-term memory problems, and they may be experiencing some occasional aphasia, and that usually looks like some like simple word finding difficulties, right? Like simple names of things that you should normally be able to produce very easily. They might just miss those things every once in a while, right? Not be able to produce those words. Stage 3 is mild decline. So we're starting to see a little more memory impairment, more occasional aphasia, so that word finding is getting a little bit more significant. Their short-term memory is deteriorating. They might be having trouble recalling people's names, and they might have a little bit of difficulty like concentrating. Stage 4 is a more moderate stage of decline. Short-term memory continues to decline, and they may occasionally have some episodic long-term memory impairments. Like they may forget who people are, who they've known for long periods of time. You may still be able to like reorient them to some of that long-term memory in this stage. Aphasia issues continue to get worse, more difficulty finding, the words to express themselves, and they develop difficulty completing multi-step tasks. So they can do maybe still simple tasks, but anything that requires multiple steps will be very difficult at this stage. In stage 5, we consider this moderately severe Alzheimer's. So these folks start to become disoriented to things like time and place. Those long-term memory impairments become more significant, and it becomes very difficult to, orient people at this stage. They may experience things like difficulty dressing appropriately. So like, choosing the right clothes for the right situation or the right temperature, those things might be off. In stage 6, we consider this to be severe decline. These people are typically disoriented to person, place, and time with profound long-term memory impairment. They also get what we call sleep pattern reversal, where they may like sleep during the day and be awake all night. I've seen patients who stay awake for days and then sleep for days. They just get these very odd sleep pattern changes at this stage. They also may start to lose things like bowel and bladder control, and many of them may become kind of like paranoid at this stage as well. And then stage 7 is the final stage. This is when we experience very severe decline. Patients might become completely unresponsive in this stage. They, probably lost the majority of their ability to both comprehend and produce speech at this time. They're also losing a lot of their motor control. Their reflexes may even become abnormal. They have difficulty swallowing, really become unable to eat at this stage. And this is when people would die from Alzheimer's disorder. So the neurophysiology of AD, what we see is this overall kind of atrophy of cortical structures, as well as the loss of a lot of neurons, neuronal density within the brain. We also associate the neurotransmitters of acetylcholine, GABA, NMDA, and L-arginine, especially decreased cholinergic transmission in the brain. That is very impaired in people with AD, and so many of the treatments that we use now to try to sort of slow the progression, or at least not even, well, I shouldn't say slow the progression, I should say reduce the symptoms of Alzheimer's disease, are things that increase the activity of acetylcholine in the brain. Another hallmark of the neurophysiology of AD are something that we call neurofibrillary tangles and amyloid plaques. Those are classic neuropathological findings in Alzheimer's disease. Usually we see those on autopsy of patients with AD. We, for years, have felt that these are probably the overall cause of Alzheimer's, that people aren't able to clear they aren't able to clear amyloid, and that's why plaques occur, and that, these neurofibrillary tangles. Our thinking about that is changing a little bit. We're not exactly sure we fully understand what those are doing to brain structures. I think we just kind of know at this point that they're there and that they're a hallmark of AD, but our understanding of exactly why they're happening and what they're doing is still evolving. But things like looking at amyloid plaques and how to prevent them is one of the major areas of focus in Alzheimer's research as far as trying to reduce the overall number of people suffering from this disease. There are also inherited forms of AD. AD does have a genetic component for everyone. If, first level relatives and families have AD, you have a higher incidence. And this genetic component seems to be especially important with people with early onset Alzheimer's dementia. So that's usually onset of dementia like before the age of 50. So the diagnosis and treatment, diagnosis is really based on clinical findings. Neuroimaging, metabolic screening are also used, but we're not using those to find Alzheimer's. We're using those to exclude any other conditions that might explain the symptoms we're seeing. So if someone is having symptoms of Alzheimer's dementia and we can't find any other underlying cause on either neuroimaging or metabolic screenings, then we would give someone a diagnosis of Alzheimer's. There's no cure for this. Medications, like I mentioned, like cholinesterase inhibitors that increase the activity of acetylcholine, or NMDA antagonists that block NMDA receptors may slow some of the progression and reduce some of the symptoms like depression and agitation and sleep disorders, but their effect is relatively minimal. Some of the bigger things that we can do with patients with Alzheimer's is really to do environmental adjustments. People with Alzheimer's disease need really consistent environments without a lot of change. They do not do well when you change their environment significantly. We also can use things like reminiscent therapy to help kind of preserve some of that long-term memory and keep people engaged. Redirection is helpful for patients, especially in the early stages of Alzheimer's, maybe not in some of the later stages, but it can be helpful early on. Things like music therapy or introducing things that people like or enjoy can also be really helpful for like reducing agitation. And the overall goals of care for patients with AD are really trying to, as long as we can, maintain their ability to socialize, but also to provide support for caregivers. Whenever we're treating someone with Alzheimer's, we're also treating their caregiver because it is a very stressful experience for caregivers. So things like offering daycare services or respite care to help support the caregivers, kind of give them a break during the day. But it also helps to provide different types of appropriate stimulation to patients as well, which I think can be really helpful for like kind of slowing depression of the or progression of the disease, as well as like preventing things like agitation. Groups like the Alzheimer's Association are very helpful for patients experiencing Alzheimer's to provide things like support groups, um, hook people up with like respite care and daycare, give them different services, help them, find support to get through this caregiving experience.